Welcome everyone to this session of anesthesia training. This morning, I'm going to be talking about benzodiazepines. So one of my favorite classes of drug, actually. Benzodiazepines are used for many different reasons clinically. Now, depending on who you talk to, they might be used for different indications. They might be used in different ways and doses. But what I want to talk to you today about is how they work, some of their properties, some of the helpful differences between the two that we use most often clinically, and then some reasons maybe why you wouldn't want to use one or some things you really need to know before adding them to your sedation or anesthetic protocol. So the very first thing I want to talk about is where they work. So the whole idea of giving drugs to animals is that you give a drug, the drug works on some type of receptor and it gives an effect in the body. So the receptor that the benzodiazepines work on is something called the GABA receptor. So this is a receptor where many different drugs work, but it just really depends on the site on the receptor where it binds. You don't need to memorize the specifics, but I just wanted to draw this out for you. So let's imagine we have an animal cell. So we've got a cell membrane, basically like the gate inside of the cell, right? And the receptor sits inside the cell membrane. It's got a part outside and a part inside the cell. And basically the purpose of the GABA receptor is that when chloride ions in the body come through it, it's going to go from the outside the cell space to inside the cell space. And what chloride will do is cause something called hyperpolarization. And basically what this will do, if this receptor is in the spinal cord or the brain, is that this will induce an inhibitory effect. So the net effect is kind of like slowing down, muscle relaxation, anesthesia, depending on what drug you're using. So benzodiazepines are on this part of the GABA receptor, so they function at this receptor, and they have a couple of different effects on both animals and in people. Generally speaking, they provide anxiolysis and sedation, and most importantly, muscle relaxation. Now, anxiolysis is a relative thing. We cannot ask dogs and cats if they have less anxiety, but what I like to say is if you have the hardware, you can run the program. And at least in people, when we give them benzodiazepines, this is what they report feeling. So we like to imagine that maybe animals feel this as well. I will say that in general, I find that injectable benzos and oral benzodiazepine medications are poor quality sedatives in dogs and cats. They tend not to provide the same kind of profound deep sedation as Dexmed or the kind of light, take the edge off quality that acepromazine has. In fact, benzodiazepines cause something called paradoxical excitement, and basically what that means is that you give it and they become really excited, they might get really vocal, they have a lot of saliva. And the reason why I put paradoxical in quotation marks is because it is frequently called this. It is not actually paradoxical, because one of the things that happens when you are inducing general anesthesia is that the first stage of anesthesia is excitement. So if we imagine that this drug is working on the same receptor as our induction agents, which I'll talk about in a later slide, it's not actually paradoxical. It's kind of what should happen naturally. But anyway, so anxiolysis, sedation, muscle relaxation, definitely the most important things they do. Anticonvulsant. These drugs are anti-seizure drugs, so you've probably seen this a lot where you work. When we have animals that are seizing or having focal facial seizures, giving them Madaz or Diaz is really what we want to do. Benzodiazepines have this really interesting property called anterograde amnesia. So basically what that means is that they impair new memory formation after the administration of the drug. So this is incredibly useful to me as an anesthesiologist because what I was taught is if you give an animal a benzodiazepine, and for some reason during the procedure, your patient wakes up or you had to shut off the anesthetic because they were doing so poorly and they were so sick, I was taught that animals will not remember that if they wake up. And the reason why we say this is because in people, when they get benzodiazepines, they tend to have impaired memory formation of their day. They don't remember getting their local block when they were awake. They don't remember being induced for anesthesia. They have difficulty remembering the recovery process. Now, there are many drugs that we give animals and people that might affect judgment of the day that they have surgery, but in people that get benzodiazepines alone, so especially like very old, very sick people getting orthopedic surgery, this is something that they report. So loss of new memory formation. So from that standpoint, giving benzos is very helpful where you have an animal where you think you're going to need to run the gas so low that maybe they're at risk of waking up. Hopefully they won't remember it. I wish we could ask them. But anyway, 15 to 29% MAC or gas sparing. This is a great property, right? So if you give an animal a benzodiazepine, not only do you get light sedation, muscle relaxation, and it provides memory loss, it also spares gas. And benzos don't do a whole lot to the cardiovascular system. So they tend not to change much about your heart rate or your blood pressure. And these are one of the reasons why they're very popular in human medicine and in veterinary medicine for use as both a unreliable sedative and as a co-induction agent. They also are reversible. So how great is that? Not only do they spare gas, don't do a whole lot to the cardiovascular system, but if you have a disaster, you can take it away. So the reversal agent for benzodiazepines is called flumazenil. The dose is 0.01 mg per kg, but basically what I would say is that if you have a 40-kilo dog multiplied by 0.1, so it would be 4, and that is the volume in milliliters that you can give. Super easy. So they provide all these great properties and they're reversible. That's really nice. So when are some situations I would consider using a benzodiazepine? Well, if I wanted any of these properties to give to my patient, I would strongly consider using a benzodiazepine. That being said, not every drug is suitable for every patient, so it is really important to be particular about your selection, not only of drug, but of route and of the situation. So make sure to critically evaluate if your patient is healthy enough for and really needs a benzodiazepine. So here's when I use them. I use midazolam and diazepam as co-induction agents with my drugs. So I will usually do something called a propofol midazolam or a propofol diazepam sandwich. And the way I like doing this is that I'll give some of my induction agent first and then my benzodiazepine. I like this because benzos decrease the amount of propofol that you need to give. And that's really nice in sick patients. The other thing is that when the anesthetic hits the brain, it's going to make them start to be anesthetized. So if they're anesthetized, they're probably not going to have the same type of paradoxical excitement as they would if you just gave that drug on its own. So I use it as a co-induction agent with propofol, alfaxolone, etomidate, and also ketamine. I usually give benzodiazepines after pre-meds, because after pre-meds, the animal at least has some type of sedation on board. So if you have an animal that you gave dexmed-hydro-IM and now you have it on the table, you're giving it oxygen, if they're very asleep from either that single bolus of propofol you gave them earlier or from their pre-meds, I think that's a good time to give the benzo. I do not give benzos to patients that are perfectly awake and sitting on the surgery table getting oxygen. The reason why I don't do that is because they tend to become very excited, and especially in large animals that might alligator roll, that might have, an excitatory reaction. I think this just makes them incredibly difficult to handle, so I don't do that. You can choose to do whatever you want and experiment and see how that works for you. When the patient isn't staying asleep. So we talked about how these drugs provide MAC sparing and they're reversible, and they provide anterograde amnesia. So let's say I have a dog, I gave it dexmed-hydro, I gave it propofol, we are doing a procedure. It is up and down. It is not staying asleep. It keeps getting tachypnic. It keeps waking up. Maybe the eye keeps rolling up and it has jaw tone. Other than evaluating, is my vaporizer full? Does this patient have pain or nociception somewhere? If I've eliminated those other things and I just want the patient to be smoothed out a little bit, I'll give them a little bit of a benzo. Because the nice thing about benzos is that the patients do this. They fall asleep and they stay asleep, which is a really nice property. If you get into a procedure, you're kind of in a situation where the animal doesn't stay asleep. You just needed to stay asleep for a little while longer. This is a great choice. When do I not use benzodiazepines? So again, it's very important to remember that depending on who you talk to, they're going to have different answers for this. This is just the way I was trained and the way I practice medicine. So I do not use benzodiazepines in animals with hepatic encephalopathy. So basically animals that have liver disease that is so awful, they are producing all of these extra toxins and they have lots of circulating ammonia and they're kind of dumpy, they're kind of dull. Maybe they're having seizures. Maybe we're treating them medically for their liver disease in the hospital. I do not give benzos to shunt puppies because they also usually have hepatic encephalopathy. An important thing to remember when I talk about those two properties is that metazolam and diazepam benzos are very, very plasma protein bound. So the body produces a protein called albumin. Albumin is made in the liver. It is one of the parameters we use to evaluate liver function, the liver's ability to make proteins. In order for drug to be metabolized by the body and then eliminated, it needs to be bound to albumin. So it is only the bound drug which is going to get metabolized and eliminated. Now, when your liver function is severely impaired, there's a blood vessel going around it, your liver doesn't get the nutrition it needs, that's a shunt dog. Or maybe you have end-stage liver failure and your liver is not doing any of those things anymore well. Maybe you're making low albumin. You're not making enough albumin. So let's say you have 3 molecules of albumin, but 10 molecules of benzodiazepine. You're going to have 7 molecules of free drug. And the free drug is just going to sit around in the body. It's going to be responsible for a prolonged, exaggerated effect of all of these things that the drug provides. So in animals with very bad liver disease and low proteins, I do not give benzos because they tend to become excessively sedate. Some animals become comatose. I have seen animals with shunts get benzos and end up on flumazenal CRIs in the ICU for 3 days. So it's just something that I don't do. If you accidentally gave it or chose to give it, I would only recommend giving like a very small dose, but that is just the way I do things. When not to use it, sometimes I will say seizure patients, I don't always give it to. And this is kind of an interesting thing, right? Because we talked about how they provide anticonvulsant properties. But the real reason why I don't give it to seizure patients sometimes is that, let's say you have a patient with seizures and you give it a benzodiazepine as part of your protocol. Let's say you wanted to wake up from anesthesia, you've given it enough time to breathe off of its gas and metabolize its other drugs, and you have the benzo still on board. Well, if you take away an anti-seizure drug in a seizure patient, that's not really going to hold up well in court. Now, that being said, I have done it. I have seen it done many times. If the patient is crashing or doing unwell and you've tried everything else, it is absolutely reasonable to give flumazenal to those animals. But I would recommend very deliberate caution when kind of going through that process and making sure that the people you're working with and maybe even the owner are aware that that is something that could happen. Very short procedures. So the nice thing about benzos is that they make animals stay asleep, but this can last for 4, 5, 6 hours. So if I have an animal that is going to get spinal fusion, it's going to be asleep for 8 hours, a benzo is going to be really helpful because it's going to smooth out the plane of anesthesia all day. If I'm doing a 20-minute pin removal on a dog, if I am doing a 45-minute TPLO, maybe you don't necessarily need the power, the staying power of a benzo. It's up to you, but I probably wouldn't do that. I do not give benzodiazepines IM almost ever, but I would definitely not recommend it in an aggressive animal. So benzodiazepines are poor quality sedatives. They can produce some excitement when given IV or IM. I tend to find that they provide more sedation, IV, after pre-meds and after induction agents, when you give benzos, IM, to aggressive dogs and cats, they become incredibly difficult to handle. So I would not recommend doing this because I do not think it's safe. If you want to give IM benzodiazepines to a 6-month-old puppy, that's totally fine. I think that's safe. They're not going to let you place a catheter. It's not going to fall asleep, but that's fine. But if you tell me you want to give a benzodiazepine IM to a police dog, I'm going to say probably not. I don't think that's safe. It might get difficult to handle. So that's just the way I do things. So now I just want to talk about some of the differences between two of the benzos we use most often in our hospitals, midazolam and diazepam. They work at the same receptor. They provide many of the same functions, but they have some very different chemical structures, and these are really important to remember when using these drugs on the clinic floor. So I'm going to go through midaz first, and then I'll talk about diazepam. I use both. I think you should try both. So midazolam, dose range for me, 0.1 to 0.5 mg per kg. If you have a healthy patient that's going to be asleep for a couple hours, I think using a low dose is absolutely fine, 0.1 to 0.3. If you have a sick, debilitated, very critical animal, you want the heavy gas sparing with that higher dose. So when I have like septic animals, bleeding animals, 0.5 mg per kg is my personal go-to. Okay, so properties of midazolam. It is light sensitive. So usually these drugs come in brown bottles. They are not stable when exposed to light. So when you draw them up in syringes, I would recommend covering them with something like Elasticon or Vet Wrap. Midazolam is relatively stable in plastic PVC syringes. You would just need to cover it. So it would be acceptable for storage in a syringe, and it would be acceptable for CRIs, either for anesthesia or anti-seizure control or as part of a mechanical ventilation TIVA protocol. They are stable in syringes, you just gotta cover them. So back to drug pharmacology, sorry everyone, but midazolam is a drug that is lipid soluble in the body, but when you give it to an animal, it gets converted to a water soluble substance. So what I mean by all of this is you want drugs to be lipid soluble because they will cross membranes. They will get into tissues faster, but in order to be metabolized and eliminated, the drug needs to be eventually water soluble to be eliminated. So this is a cool property, right? Like it's lipid soluble in the body and lipid soluble in the bottle, but then you give it water soluble. Neat. Formulation, it's kind of liquidy. You draw it up, it looks like basically everything else you could draw, which we're all familiar with. No solvent, it's just in the bottle. It tends to be more potent and have greater receptor affinity for the GABA receptor than diazepam. It doesn't mean it's better. Potency just means I need a lower amount of drug to give the same effect. Because look at this. Midazolam, you're going to get different amounts of sedation between both, right? But you can give 0.1 of midazolam and still get the effects, but you would have to give 0.5 of diazepam to give those effects. So potency is just having to do with that. It doesn't mean it's better. It doesn't mean you should choose one or the other based on that. It doesn't really matter to me. And it has greater receptor affinity. So basically it just is more likely to bind and find that GABA receptor. Doesn't mean it's better. It has more propofol sparing effects and more sedative effects than diazepam. So there's a study they did where they gave propofol midazolam sandwiches to dogs getting induced for anesthesia, and they found that giving midaz with their propofol helps you cut down on propofol. Diazepam tends not to do this. The sedative effects of diazepam tend to become apparent much later than midaz. Midaz usually works pretty quickly when you give that IV. So that's basically the lowdown on midazolam. Now I'm going to talk about diazepam. So diazepam, I usually dose at 0.5 mg per kg across the board. It is also light sensitive. I would recommend protecting bottles and syringes from light, and usually the bottles are brown. Something that's very important to remember about diazepam is that it adsorbs to PVC plastic syringes. So basically what that means is that it's going to stick to the inside of PVC syringes. And what that means is that less quantity of drug is going to be made available for the patient. So for this reason, I would not recommend putting animals on diazepam CRIs, and I would not recommend storing diazepam in plastic syringes. It is not stable. If you need to put an animal on a benzo CRI, I would recommend using Medaz. It is water soluble, diazepam, and the formulation, it's very viscous. It's very thick. Recommend drawing it up with at least a 20 gauge needle. Otherwise, it takes quite a long time to get into the syringe. It stings IM. It also has a propylene glycol solvent. So this just has to do with the formulation that particular drug has. And like I said earlier, when comparing it to midazolam, the sedative properties tend not to be apparent right away, but you do still get max sparing, amnesia, anti-seizure effects. But, unlike Medaz, they're probably not going to fall asleep right away, but it will become apparent over time that they have had a benzodiazepine. So that is basically the summary on benzos. They have all these lovely properties. They are reversible, but there are certain situations where you might want to be very judicious about your use of them. It's fine to use either of these, but depending on whether you need just a bolus or a CRI, you might choose one over the other. And let me see. And that's it.